via phone. The Project Echo philosophy is all teach, all learn, and that underpins this program. So we encourage everyone to ask questions, make comments during the session by using the chat box. And then when we have a Q&A session, please feel free to unmute yourself, use the raise your hand icon, or you can actually physically raise your hand. And then you can, to ask your question, you can privately chat with the session host, which you can see under Akita-Echo, or with any member of the Hub team. They're all noted with Hub or Hub team in their names. So if you want to have your question shared anonymously. And again, please introduce yourself if you're just joining us with your name and your organization. And a reminder that the opinions of the Hub team and the presenters are their own and do not necessarily represent Akita or the Echo sponsors. And additionally, Project Echo is not HIPAA compliant. So no public protected health information is to be shared or displayed at any time. So thank you all for following those guidelines. And I just want to take a moment to pause for land acknowledgement. And though this is a virtual space, our Echo team is joining you from Anchorage. And as such, we want to thank the Dena'ina people for their stewardship of the lands, water, air, and all life that sustains us within their traditional lands of the Takatnu Cook Inlet region. We respect the Dena'ina cultural ways and their homelands and shall strive to be good neighbors. And now with this, I will turn things over to today's Hub facilitator, Jenny Loudon.
Thank you, Beth. And I am here. I'm Jenny Loudon, and I am the other Akita co-founder along with Beth. And the goal of today's Echo is really to help work together to grow capacity within our local healthcare systems so that we can better understand, diagnose, and treat eating disorders. And today we're thrilled to be talking about avoidant restrictive food intake disorder, which we also often call ARFID. And what we know is that ARFID can sometimes look quite different from other eating disorders, but just be just as detrimental and harmful to the individual. And as one of the newer diagnoses within the DSM-5, many health professionals are not as knowledgeable about how to adequately diagnose and treat it. So we are thrilled to have Dr. Bermudez here today to help us learn more. So Dr. Bermudez is a world-renowned eating disorder expert, physician, and advocate. He is the senior medical advisor for Eating Recovery Center and affiliates. He also holds academic appointments as a clinical professor of psychiatry and of pediatrics at the University of Colorado School of Medicine and the University of Oklahoma College of Medicine. He's board certified in both pediatrics and adolescent medicine. And in addition, I will just add that Dr. Bermudez has really a lifetime of very significant contributions to our field. Here in eating disorders. He is a fellow of the American Academy of Pediatrics, the Society for Adolescent Health and Medicine, the Academy for Eating Disorders, and the International Association of Eating Disorders. He's also on the board of directors for the International Association of Eating Disorders Professionals. And interestingly enough, has also helped co-found two state-level organizations that are very similar to how Akita works and helps those in Alaska. He helped co-found two organizations in Oklahoma and Tennessee. So he's very familiar with the kinds of work that we're doing here in Alaska. I will just add that he has also received Lifetime Achievement Awards from both the National Eating Disorders Association and IDAP. So we are just incredibly grateful to have his expertise here with us today as we all grow together to better help those with ARFID. So I will just, before turning it over to Dr. Bermudez, I will just let you all know that we have about 12 minutes or so adjudicated in our time today for live Q&A and discussion after the presentation. So we will encourage all of you to be thinking about what kinds of questions that you might have for Dr. Bermudez after his presentation. And with that, I'll turn it over to you, Dr. Bermudez.
Thank you, Jenny, very much. I'm going to try and share my screen. And let's see. Well, there it is. So as you can see, small miracles do happen. Anyways, good afternoon, everybody. It's good to see so many faces. And I am glad you used the format of encouraging people to use their cameras because it's nice to see faces rather than talking to a computer you know how that goes. So let's get going here, because I think time is of the essence, so that we leave some time for discussion, which I think is probably the most important part of this. So I want to preface by saying that it is imperative for anybody involved in healthcare to understand that if a child loses weight, a child derails their growth rate, both in height and in weight, or if a child stunts their growth, these are medical emergencies, regardless of the etiology. So whether it's anorexia, whether it's ARFID, whether it's a malignancy or not, those need to be buzzwords where we say, what's going on, and let's go understand this. So it's been about 10 years since the publication of DSM, well, not about, exactly 10 years since the DSM-5 came out. And then ARFID was introduced. It was a new word, so new language, under the umbrella of feeding and eating disorders. And of course, the important change there, one of the important changes was that they were now talking about across the lifespan, so not just in childhood, and that's really important. So the clinical presentations of ARFID have increased in our settings, all clinical settings across the lifespan, particularly still in children and young teens. And we're seeing rapid evolutions with severe malnutrition, very severe complications, children who have not grown in a couple of years, or adults that come in very, very compromised. And this is particularly true since the COVID-19 epidemic. And this is not unlike other eating disorder presentations in which we've seen that rapid acceleration of symptoms and rapid deterioration. So really important, early recognition and timely but effective intervention continue to be our critical tools. Our experience at Eating Recovery Center is as follows. Our first ARFID diagnosis was that we admitted to our system was in September of 2016. Since then, and as of March of this year in Denver, there have been 667 admissions with a primary diagnosis of ARFID. This is across the lifespan. And at all ERC sites across the country, we have seen 3,238 patients admitted, again, of all ages. So we have a significant experience with this. And my sense is that it's imperative that as a field, those of us professionals from any background interested in eating disorders, that we are become very familiar with ARFID. This is not going away. Actually, if I was a young clinician or a young researcher, this would be my point of emphasis, because of the way that this has turned out. So let's talk about ARFID definition, prevalence, diagnosis, and a little bit of overview of management. But again, with the emphasis that our primary opportunity is with early recognition and timely and effective intervention. So let's talk about the definition. So here's the catch, so to speak, right? A large number of patients, individuals, primarily but not exclusively children and teens, substantially restrict their food intake and experience significant associated physiological and psychological problems, but do not necessarily met criteria for any DSM-4 eating disorder diagnosis. So ARFID came forth as a broad category, really intended to capture this range of presentations. And of course, what we're really beginning to understand, and what's also one of the key issues that I hope you take from this conversation, is that we're not talking about one entity. We're not, restrictive anorexia nervosa has been restrictive anorexia nervosa for 500 years. It is unchanged. The conversation with an 8-year-old or an 80-year-old with restrictive anorexia nervosa today or 200 years ago is identical. With ARFID, that is really, really, really not the case. So as clinicians, we need to become really savvy. Here's the deal. These are the diagnostic criteria. I'm not going to read them to you. I think that would be less than productive. But what I do want to touch on is that, we essentially look at this deficiency in intake, sort of justified by a variety of reasons. We'll talk about subtypes in a minute, that lead to one of these four categories, right? Significant weight loss or failure to achieve expected weight gain or faltering growth in children. I mentioned those three issues, right? So any child in whom that is identified, it begs the question, why? One of the challenges that we still face is that, a parent will experience a child that stops eating, loses, 5, 6, 7 pounds, let's call it a 10-year-old, on a percentage basis. That's not huge, but for that, developmentally speaking, that is a huge amount of weight loss. And they approach healthcare, and healthcare says, it's okay, this may just be something that will pass. Then we lose the golden opportunity, that early recognition, timely, effective intervention. This tends to lead to significant nutritional deficiencies. So it's not just growth, they become malnourished, dependence on enteral feedings or oral nutritional supplements. So we admit a lot of patients to our system. Of those 3,200 patients, a very large number has come on only liquid intake or dependent on tube feedings. And then the fourth criterion is really important, marked interference with psychosocial function. Because if it only takes one of those four, what this says is that you can be a normal weighted, right, non-malnourished individual and meet criteria for ARFID because of the significant interference with psychosocial functioning. So it's not only the malnourished, we need to think more broadly than that when we think about ARFID. And then the rest of the criterion basically speak to this doesn't happen because food is not available, it's a culturally sanctioned practice. This cannot coexist with anorexia and bulimia. That's really important because I'll touch on that a little later. And it's not attributable to a concurrent condition, right? If you have a primary psychosis, you're paranoid and you believe your food is being poisoned and you stop eating because of that, that is not ARFID. That is a primary psychosis. So important to be thoughtful about that. What is it? What's the elevator message? It is a serious eating disorder whose medical complications, when underweight and malnourished, are commensurate with that, with the degree of underweight and malnutrition, and very similar, if not identical, to that of anorexia nervosa. So it's not a lesser diagnosis by any means. It's just a different mechanism of disease, if you will. What it is not, it is just picky eating in kids. Most people with ARFID, most, not all, but most people with ARFID will relate to some history of having been picky as a child and now grew it, picky their entire life, etc. It is not a lesser eating disorder. We lived through that with EDNOS, right? Until we found out that the mortality rate of anorexia, bulimia, and eating disorder not otherwise specified was actually similar, right? So it wasn't a lesser diagnosis. You could still die from the old DSM-4 EDNOS. It is not simply a behavioral disorder. This is not about changing behavior. It is a mental health issue, and it should be taken very seriously as such. And please, let's not reenact what we did with anorexia. This is not caused by parents. The lure is very strong because if you're an 8-year-old that only eats chicken nuggets of the McDonald's in the corner and they have to be left-footed chickens, right? It begs the issue of, my gosh, somebody's enabling this, right? But as my mentor, Craig Johnson, often said, if you're raising a budding schizophrenic child, you parent them different, don't you? And so to me is the notion of this is not about parent blaming. This is about understanding that parents try to adapt as best they can to do the best they can by their kid. So we need to move away from that. Prevalence, well, more data is coming along, but the truth of the matter is that the incidence and prevalence are still unknown, and we have evolving subtypes. So how, it would be very difficult to say, like with anorexia and bulimia, I think we have solid data. But then we have to think about, the incidence and prevalence of anorexia and bulimia are different, for example, in the general population compared to a college age population, especially if it's a highly competitive college. So it's not simply a number, it's an understanding that these are prevalent illnesses, and so is the case with ARFID. Still more common in children and teens, less common but not absent in late adolescence and adulthood. So throughout the lifespan, all genders, and often associated with psychiatric comorbidity, like with anorexia and with bulimia, but especially with anxious and obsessive compulsive features. A lot of these people fit into the autism spectrum, hence the rigid thinking, less associated with depression, although in medicine, one can never say never. So important to be thoughtful, about that. So let's talk about diagnoses. And if I'm going too fast, somebody slow me down. But when somebody tells me 30 minutes, I'm a stickler for that one. So I'm trying to get through this material with you, and then we'll obviously have the case presentation and the like. So let's talk about diagnoses. And 10 years in medicine is nothing, right? There are some data that says, and this is before the internet, maybe the internet, Dr. Google has accelerated this in some rate, to some extent, but there were data saying that between a novel discovery in medicine and widespread implementation, there could be as many as 15 to 17 years. We still have emergency rooms that if you're a guy my age and you show up with chest pain, somebody doesn't think to give you an aspirin right away. And the evidence behind that is so robust, right? So it is widespread, but it's not 100% practice. So this is still a new diagnosis. We need to give ourselves a little slack for that, if you will. Many clinicians are still not familiar, especially with this diagnosis and lack knowledge about the diagnostic criteria. And this tends to lead to two things: either misdiagnoses, right? The children that are diagnosed with food intolerances, and that's why they don't eat, because they get nauseous and they're afraid to throw up, and they cut back their eating and cut back their eating. And so the focus becomes, well, this is a food intolerance or a food allergy, as opposed to, we've got an anxious syndrome, an anxiety syndrome, and this is really an eating disorder and a mental health issue, not a gastrointestinal issue or an allergy issue. But the other aspect that is really important is that many ARFID patients are very focused on their physical symptoms. So they don't tend to seek initially, the way they're seeking for that answer is not in mental health. They're seeking for that answer in medicine, physiological health. And so that tends to delay the diagnoses in testing and testing and testing. I often say to people that I teach, I get it. If somebody comes to me and says, my tummy hurts, I'm always nauseous, I'm terrified of throwing up, and somebody does a colonoscopy, for example, right? Or an EGD, an upper endoscopy. I can understand that they go see somebody else and they repeat that. They have a second colonoscopy or a second upper endoscopy. But we're admitting patients that have had, 5 of these over a period of, 2 or 3 years. To me, what are you going to find on the 3rd and the 4th and the 5th that you didn't find in the 1st and the 2nd? So all it does is sort of delay the diagnosis. And like with anorexia, the passage of time in this marinade, right, in this malnourished, weight suppressed, growth suppressed state, is not just the physiologic consequences, the bradycardia and the amenorrhea and the loss of bone mass. The problem is we have a brain marinating in absolutely the wrong marinade. So these behaviors become hardwired, and then they're much more difficult to overturn. Important to think about that as we think about early recognition and timely intervention. The diagnoses, the presentations vary widely and may both depend on and evolve with the developmental context, right? Like these are developmental illnesses in a way. It's a good way to think about them. The lack of drive for thinness, which is one important aspect of the diagnostic criteria, can be confusing to families and clinicians. I want to eat more. I want to weigh more. If one of these patients is asked, do you like your body? Do you have problems with body image? Yes, I do. Look at my bones sticking out. I don't like that. That's very confusing, because if somebody's saying, I want to weigh more and I want to eat more, but they're not, right? They're losing weight and not eating. It's really confusing. And for families, it's confusing. For clinicians, it's confusing. And again, we mentioned that the medical complications when underweight and malnourished are identical to that of anorexia, is not a lesser diagnosis. Now, the very term avoidant restrictive food intake disorder implies a bifurcation, implies that we have avoidant food intake disorder and we have restrictive food intake disorder. And they're very, very different, if you will. We have evolved that. We're now working on 5 subtypes. I think the literature clearly speaks to 3 subtypes, but I think we are clearly seeing 5 and even some novel presentations beyond that, but maybe that's out of the scope of today. So let's talk about those. And I want to touch on 4 of the 5 that we're working with: avoidant, and aversive. So we divide avoidant and aversive, and restrictive as restrictive, and then we see mixed type of presentation. So let's go over those quickly. So avoidant refers to individual whose food refusal is really related to either the avoidance of adverse or fear-based experiences. We call it a phobic avoidance stance. So fear of choking, global sensation, something is stuck in my throat permanently when it's not. If it is, well, then fear of nausea, phobia of vomiting, phobia of abdominal pain, swallowing pain, esophageal pain, swallowing in and of itself as a phobic type of fear, and a phobia of anaphylaxis. I mean, it should say phobia and not fear, because if you've ever experienced anaphylaxis, you should have fear of it. But phobia means that, you cannot be in a building, you cannot be in the first floor of a building where somebody may have a peanut butter sandwich on the 10th floor because you have peanut butter allergy, right? That's above sort of logic and reason, and many of these patients become really caught up, stuck in that. Then we divide the second aspect of the avoidant is avoidant or aversive, and these are people who only eat certain things in relation to sensory features. So they have aversive sensations, sensory experiences, and we call this sensory sensitivity. The sensory aversions may be only to food or be more global, involving other senses, touch, smell, color of food, for example. Some of these are very focused on the experience of the food in the mouth, but others are about, I see food, it looks a certain way, and I can't handle that. I smell it and it smells a certain way. So it's not only about the act of putting food in their mouth, it's also about other experiences related to food. For many of these patients, it's about not just an aversive feeling, but an overstimulated feeling, almost like super tasters. And they can have preferences for, may tolerate bitterness, but not sweetness, may tolerate sweetness, but not bitterness. So it's not one size fits all. It's complicated, and a very detailed history is really important. And if it's truly long standing since infancy and multi-sensory, then we need to consider sensory processing disorder as part of the differential diagnosis or comorbid diagnosis sort of picture. Restrictive is restrictive, low appetite drive, disinterested in food, often since a very young age, often extreme pickiness, not just picky. A lot of these syndromes share the picky eating early on, but extreme pickiness, often distractible and forgetful, so gamers, wishing they would eat more, cognitively rigid, often the autism spectrum. We've described the syndrome of the lone wolf syndrome as the individual with these characteristics that finishes high school, they limp along, they try to launch to college, they cannot, and come back home, no other option, and become extremely isolated and extremely angry. And you can imagine the leave me alone stance that prevails. And then mixed type is complex. It's complex because it's complex diagnostically, it's complex therapeutically, and you have most of the time you have restrictive ARFID that then acquires an avoidance sort of stance. So the prototypical combination in a mixed type is somebody who grew up extremely picky, disinterested in food, restrictive, but maintain some growth. And then they are 12 years old and they watch somebody choke at the table, and then they become terrified of choking themselves. And now you have a mixed picture, and they stop eating, they lose weight, they stop growing. You get the idea. So, important to be thoughtful. And therapeutically, this has implications because you may have to peel that onion differently than somebody who has a very stable syndrome. You can focus on one thing rather than having to focus on multiple issues. The developmental context becomes really important. So the age of presentation is very important. So the assessment and the treatment may differ for a child, an adolescent, a young adult, or an adult that may have a very similar presentation. But we need to think contextually of the developmental sort of timing of that. In adults, often misdiagnosed as anorexia nervosa. And this is really difficult and confusing. We admit a lot of patients with ARFID that have been treated for quote unquote anorexia for quite some time. And the key there is I'm not seen. Nobody has seen me. Nobody, I'm see-through, so to speak, because nobody gets what I'm talking about. I don't want to lose weight and I don't want to be thin, and yet I don't eat. And people tend to confuse that altogether. The age of onset is also important, not just the age of presentation. So adults with avoidant, aversive, restrictive, or mixed types of ARFID may have had similar symptoms since childhood, but others may have had other features of sensory integration disorder since childhood. And if the onset of ARFID is in late adolescence or adulthood, it typically involves food-related adverse experience, choking, vomiting, abdominal pain, right? You hear of a lot of stories of the patient that developed, an acute gastrointestinal illness. They vomit it and they become terrified of it, and they just simply don't rebound. So that failure to rebound from the experience of having had such a series of symptoms is often the trigger. So it's unlikely that an adult would have had no restrictive symptoms and no sensory aversive issues their entire life, and all of a sudden, voila, develop ARFID. Most likely, then we're talking about fear of adverse consequences, if you will. Management, let's talk quickly about this. I mean, I think we go at Eating Recovery Center, we go through a comprehensive pre-assessment and admission assessment that focuses very much on identifying the ARFID type, because we're going to treat them differently. So it's really important not to say, if you have ARFID, we do the same thing. No, not really. We don't do the same thing for anorexia and for bulimia. And we should not be thinking we do the same thing for restrictive ARFID versus aversive ARFID versus avoidant ARFID. The core issues of treatment need to be recognized and respected. So people who are medically unstable, they need to be stabilized medically. So if your heart rate is in the 30s, it doesn't matter whether you have anorexia or ARFID. A core issue is we need to stabilize you for safety. Psychiatric stabilization, people with significant self-injurious behavior, suicidal tendencies, suicide attempts, that becomes really a priority as well. Nutritional rehabilitation. Underweight people need to be nutritionally rehabilitated carefully to avoid refeeding complications, and they need to normalize their weight. So weight and height restoration when it's faltered, especially during periods of growth, absolutely an emergency, absolutely critical. So the treatment per se depends on the ARFID type. For both avoidant and aversive types, exposure and response prevention should be the hallmark. It's not the only approach, but it has to be the base, the foundation. And for restrictive types, we're talking about family-based therapy informed, right? We're not going to do family-based therapy with a 40-year-old with a restrictive ARFID, but FPT informed, right? Approaches with emotion-focused family therapy, emotion coaching, meal coaching, making sure that we teach the support system how to, because this is not a construct that's going to change overnight. This is not like depression that we can treat it and it can simply go away. If somebody's been restrictive all their life, they're unlikely to change that overnight. So the critical ingredients are expertise in all specialty areas: nutrition, psychotherapy, medicine, psychiatry, confidence in working with families. Again, we're talking mostly, not all, but mostly about children and young teens, although at any age, the context of the support system is very, very helpful. Tight communication with other providers, with referring providers within our teams, with families, with patients. They need to feel understood. They need to feel that we get it. If not, it's very difficult to help them. Ability to individualize care while still adhering to the core principles of treatment. So yes, there are aspects of every treatment approach that say this is a unique human being and we need to individualize care where we can without ignoring the core principles of treatment. And overarching, the treatment goals are: if you're a disinterested individual, if you're a disempowered individual, I can't help my fear. I think I'm going to choke every time I put something in my mouth. Or if you're a disinterested individual, you're distant and eating is not a priority to me, we need to change that to you feeling empowered and feeling motivated. So overall overarching, somebody's got a cute cat crawling behind their couch. Outcomes wise, well, we're learning as we go, but let's face it, the data is still quite limited. Likely variable outcomes depending on the subtype of ARFID, the age of onset, the age at presentation, what psychiatric comorbidities are present, to what extent they are significant, and the like. So it's not the same to have ARFID and autism spectrum and OCD than to just have ARFID with a little sort of rigidity, if you will. Those are different issues. So some overarching themes, some pearls that I want to leave you with is we're talking about serious medical complications, often extensive medical workups and interventions before the diagnosis is clearly made, and this can carry significant growth impairment. Shame is often a common denominator that tends to delay diagnoses. People tend to not seek help because they don't understand. I mean, this is not okay. Why is this happening to me? Why is this happening to my child? So delays in diagnosis and treatment is a reality for families and patients. And like with working with all eating disorders, it's a marathon. It's not a sprint. So shape expectations, the need for ongoing treatment, aftercare. I mean, part of my interest in supporting you guys as an organization to tool up is because it's really important to us to have patients to send back to adequate care once they come through our treatment experience, because that's critical for long-term success. And so I think we're still learning much more to be said. One of the things that I think is really important right now is to understand that we're already seeing an overlap between ARFID and anorexia nervosa. So the DSM-6 or the text revision of DSM-5 is going to address that, because saying that ARFID and anorexia cannot coexist, they're mutually exclusive criteria, is just simply not what we're seeing clinically. So there is a good example of, kind of what's ahead. This is going to continue to shift, and we're going to continue have the need to continue to stay up to date and updated. So thank you for your attention, and I'm really looking forward to hearing the case and having a little bit of time for discussion.
This is wonderful. Thank you so much, Dr. Bermudez. This is such an informative presentation and such important information on a diagnosis that I think a lot of us are still learning a whole lot about. I would like to open up the floor for questions and comments. Remember, there is no such thing as a dumb question. So if you want, you're welcome to raise your hand using the raise your hand feature, and then you can unmute yourself when called on, or you can also put your questions in the chat. So we'll start with a couple of questions that have already been provided to us in our chat. So one question is this condition less prevalent in adulthood, or is it just that it's simply less often diagnosed?
No, I think it's less prevalent in adults. And the reason for that is that, if you have one of the onset in infancy or early childhood syndromes, right? If you're really, really restrictive, or if you're really, really aversive, well, chances are that this is going to surface before you get to be 30 or 40 years old. So it's the more sort of avoidance stance, right? The phobic avoidance, the fear stance, that I'm afraid to choke, I'm afraid to hurt, I'm afraid to vomit, that tends to present de novo at some point. And those are the majority of the patients that we see in adulthood, as a de novo presentation, tend to fit into that particular category. Can people have some features of restrictiveness and the like, and be a little ARFID-like most of their life, and then fall into that sort of avoidance stance? Sure, absolutely. But I think that's a different tease out than, no pathology and then onset of this pathology versus sort of indolent pathology, right? Some features, but you don't really meet criteria, it doesn't really affect your life, and then all of a sudden, boom. So we're talking about, I think less prevalence in adults and more prevalence in children, just because of the subtypes sort of lend themselves more to be part of a child's journey and really present with significant interference earlier in life.
Great. Couple more questions that I've seen so far. So how would you say that conversion disorder, for example, someone who's not swallowing even their own saliva, fits in this, or maybe does not fit in this with this ARFID diagnosis?
Yeah, so I mean, I think conversion and ARFID are different. For ARFID, for example, I think they share people who are impressionable, right? People who have an experience and get stuck with it, so to speak. But to me, you're talking about a very different context. I mean, I do think I have seen, and I do think that there are conversion disorders that focus on swallowing and interfere with eating, for example. But conversion disorders present in a much broader sense, across the experiences that, of the symptomatology that patients experience. So to me, ARFID is more focused on food all along. Should conversion disorder be in a diagnosis of a de novo ARFID presentation kind of out of the blues? Absolutely. I think it should be a consideration, but I think there's also a differentiation.
Great, thanks. I'd love to give Karen Callan Brown a chance to ask her question. Do you want to unmute yourself and ask your question?
So if you have a young teen who has issues eating, chronic upset stomach, reports that they're vomiting 30, 40 times a day, what should I be asking the doctors to look at? And what should I be doing as a counselor?
Did I hear you say vomiting 30, 40 times a day?
That's what they're telling me.
Yeah. So,
and the Guardian is reporting concerns that they're not hardly eating, and I don't know what's true or not.
Yeah. So look, like in everything, right? The poison is in the details. I don't think that humans can survive vomiting 30, 40 times a day very long. A human may spit up, right? Babies spit up many, many times a day, but that's not vomiting. The physiologic consequences are different. And not eating, I think we have to be careful in sort of quantifying that. So there is a qualitative aspect to that, right? What is it that they're eating if they're not eating? So if you eat, you're a small kid and you eat 2 chicken fingers for one meal and a little bowl of macaroni and cheese for the next, that may sustain you calorically. So not eating is about, again, quantifying it and qualifying it. So to me, it's about a careful assessment, looking at growth curves, looking at past records. Where is this child's growth in height going? Where is this child's growth in weight going? Has there been weight loss? If you're vomiting 30, 40 times a day, your weight is dropping very precipitously. So to me, it deserves a very careful look. And if in doubt, hospitalize that child, right? And take a look at what is the data? What are the vital signs saying? What are the laboratories saying? What was their EKG saying? Do we need a gastroenterological consultation? So I would not ever ignore the medical differential diagnoses and the psychiatric differential diagnoses. I just think that at some point we need to say, this is an eating disorder with comorbid depression or comorbid anxiety, and that's how we need to approach it. The last thing I want to tell you is that not all people that look like ARFID actually have ARFID. So there are case reports in the literature, for example, of somebody with swallowing difficulties that eventually avoid eating because of the discomfort in swallowing. There's one case reported in which there was an aortic arch. So the vascularity was malformed, right? The artery surrounded the esophagus, and sure enough, when you swallow it would hurt. So we got to be careful. We got, like everything in mental health, we cannot jump into it. We cannot assume that it's the only diagnosis, but sometimes we need to conclude with, if it looks like a duck and quacks like a duck, it's a duck.
Great. This is an excellent question. So is there a tool that you would specifically recommend for helping to diagnose ARFID? Should they be looking at assessment questions, height, weight charts only? Are there other things on physical exam that people might notice?
Yeah, there is a validated questionnaire out of Mass General. I forget the acronym, but I'm sure you can look that up. And the key there is that it's validated. So to me, questionnaires help in 2 ways, right? They educate us as to what are the questions that we should be asking and how do we interpret those questions? So they make us better clinicians if we're familiar with the questionnaires. And if they're validated, then it's more objective data to support a diagnosis. So that's the yin yang to me. And I think we will see more about ARFID, except that ARFID is a moving target, right? So we're talking about a heterogeneous pathology. This is not a straight pathology like restrictive anorexia, for example, and it's evolving. So
great. Thank you, Dr. Bermudez. I wish we had more time for more questions, and maybe we'll have some time at the end.